Okay, so next we're going to be talking about descriptive terminology. This is on chapter 31 of your dental radiography textbook. So the learning objectives for this chapter include defining descriptive terminology and describing why the dental professional should use descriptive terms and to differentiate or tell the difference between descriptive terminology and a diagnosis. Compare and contrast the terms radiolucent and radiopaque, and to do the following related to how to describe radiolucent lesions. Identify radiolucent lesions on a dental image in terms of appearance, location, and size. Define and discuss the terms unilocular and multilocular. Define and discuss the terms periapical, interradicular, edentulous zone, pericoronal, and alveolar bone loss in relation to radiolucent lesions, and to do the following related to how to describe radiopaque lesions. And this is to identify radiopaque lesions on a dental image in terms of appearance, location, and size, to define and discuss the terms focal opacity, target lesion, multifocal confluent pattern, irregular or ill-defined opacity, ground glass opacity, mixed lucent opaque lesion, and soft tissue opacity. We'll define and discuss the terms periapical, interradicular, edentulous zone, and pericoronal in relation to radiopaque lesions. So what is descriptive terminology? So in a dental image, a number of dental terms can be used to describe the appearance, the location, and the size of the lesion. And these terms represent what is called descriptive terminology. This information should be documented for all lesions viewed on dental images. So why use descriptive terminology? Well, descriptive terminology allows dental professionals to intelligently describe and discuss what is seen on dental images and to communicate using a common language. Communication among dental professionals about dental image findings takes place each time a case is discussed or when a patient is referred to a specialist for evaluation. The use of descriptive terminology reduces the chance for miscommunication among the dental team. And descriptive terminology also allows the dental professional to document what is seen on the dental image in the patient record in terms of appearance, location, and size. And documentation of what is viewed on dental images is essential for legal purposes. A written description of what is viewed indicates that a qualified dental professional has interpreted the dental image. So descriptive terminology versus diagnosis. In describing a lesion, the same, so descriptive terminology allows the dental professional to describe what is on the dental image without implying a diagnosis. And a diagnosis is the identification of disease by examination or analysis. It is important to note that it's extremely difficult, if not impossible, to establish a diagnosis just from a dental image alone. That's because an evaluation and analysis of the patient's medical and dental histories, clinical findings, signs and symptoms, lab tests, and biopsy results are what allow the dentist to make a definitive diagnosis. So we'll review a few of the basic terms, and that is radiolucence versus radiopaque. We'll describe how to describe, or we'll go over how to describe lesions, as well as the terms used to describe radiopaque lesions. An understanding of how to describe lesions viewed on dental images using the appropriate terms is essential for communication. So the terms radiolucent and radiopaque are used to describe appearances of all the structures seen on your dental image. An image appears radiolucent, black or dark, where the tissues are soft or thin, and appears radiopaque, white, which is white or light, where the tissues are thick or dense. And radiolucent refers to the portion of a processed dental image that is dark or black. Dental caries appears radiolucent because the areas of the dental caries is less dense than the surrounding structures and therefore readily permits the passage of the X-ray beam. And that is because dental caries happens because microbes have um, basically eaten away the structure of the tooth. And when they do that, they decrease the density of the tooth. And that's what causes the image to appear radiolucent. So consequently, most of the energy of the X-ray beam freely passed through the area of dental caries to the recording surface of the receptor, resulting in a dark or radiolucent area on the dental image. And radiopaque refers to that portion of the dental image that appears light or white. Radiopaque structures are dense and absorb or resist the passage of the X-ray beam. So a metallic restoration looks radiopaque because it's very dense and absorbs the radiation. And as a result, very little, if any, radiation reaches the surface of your receptor, which results in a white or radiopaque area on the dental image. So here you can see on this image here on the left, we see dental caries. It looks like a distal occlusal lesion on tooth number 5. You can see this dark shadow that's kind of invading the tooth structure or what's left of that tooth structure. And so this area would be known as a radiolucent area. Radiopaque, on the other hand, on the image on the right, we see metal substructures of crowns that are extremely dense and they thus absorb all the radiation. So this part of the tooth or this part of the film that that your image was exposed on is not exposed because there was that dense metallic object that kind of absorbed or prevented those X radiation from getting to your receptor. So that's why certain things look radiopaque. So as far as how to describe images, in order to properly document a lesion seen on a dental image, the lesion must be described in terms of appearance, location, and size. The appearance of most radiolucent lesions can be classified as either unilocular or multilocular. Unilocular radiolucent lesions um, have one compartment because the term unilocular is derived from two Latin words. Uni means one, and loculus means a small space or compartment. And it refers to a radiolucent lesion that exhibits one compartment. Unilocular lesions tend to be small and non-expansive and have borders that may appear corticated or non-corticated on the dental image. And corticated just means that the bone has is thicker in the area than the normal than it normally would be. The term corticated comes from the Latin cortex or outer um, outer layer and refers to the outer layer or border of a radiolucent lesion. And a unilocular radiolucent lesion with corticated borders exhibit a thin, well demarcated radiopaque rim of bone at the periphery or the border. A unilocular corticated lesion is usually indicative of a benign, slow growing process. And benign just means it's not cancerous or not harmful. Um, Unilocular lesion with non-corticated borders does not exhibit a thin radiopaque rim of bone at the periphery. Instead, the periphery of the unilocular non-corticated lesion appears fuzzy or poorly defined. A radiolucency with ill-defined or irregular margins may represent either a benign or a malignant process. Multilocular radiolucent lesions refer to a lesion that exhibits multiple radiolucent compartments that resemble something like soap bubbles. A multilocular lesion with multiple compartments is typically larger than a unilocular lesion with one compartment. And a multilocular radiolucent lesion is frequently large and expansive and tends to displace the buccal and lingual plates of the bone. Multilocular lesions are typical benign lesions with aggressive growth potential. In addition to appearance, radiolucent lesions can also be described in terms of location. The location of a lesion is important for communication and documentation purposes. A, a radiolucent lesion may appear in a periapical, interradicular, edentulous, or pericornal location. A radiolucent lesion may also appear as alveolar bone loss. So it's important for communication as well as documentation purposes to understand the location of certain lesions. So here we have a periapical location. And a periapical location is just when you see a lesion that's located around the apex of a tooth. For example, a periapical cyst secondary to pulpal necrosis is basically a fancy way of saying that there is an infection at the root of the tooth. And as you can see in this image, if you look down where the apex of the tooth is, we see this little bubble or this little round radiolucent area. And that's where the infection has kind of invaded the bone structures, and it's actually eating away at the bone structure there, which causes a lower density and causes that radiolucency that we see there. Next, we have an interradicular location, and this is a lesion that's located between the roots of adjacent teeth. For example, here we have a lateral periodontal cyst. And so that's just talking about in between the roots. So here we have this lateral periodontal cyst. It's just some sac of, it can be either fluid or blood or some other type of tissue that's invading the bone tissue there. And that's what causes that radiolucency. So the prefix inter means between, and the combinations form radicular, which means pertaining to a root. Next, we have an edentulous zone, and this refers to an area without teeth. Edentulous means without teeth, and a variety of radiolucent lesions may occur in an edentulous zone. So edentulous zones are just referring to these spaces where there is no teeth. A pericornal location refers to the area around the crown of an impacted tooth. You can see here that number 32 here is an impacted tooth. And this lesion, we call it a dentigerous cyst. This is a lesion that's forming around that pericornal area. And pericornal comes from the Greek word peri, which means around, and corona, which is Latin for crown. Alveolar bone loss refers to the loss of maxillary or mandibular bone that surrounds and supports the teeth. Alveolar bone loss appears radiolucent and is seen not only in periodontal disease, but also with systemic diseases such as diabetes, histiocytosis X, and leukemia. Malignant neoplasms can also cause alveolar bone loss. And here's just a diagram. Just because it's kind of hard to know what you're looking at first on an x-ray, we have these little diagrams that show us basically what that alveolar bone loss is. And so see here, you can see these teeth that are supposed to be kind of cemented in this alveolar bone. And we can see here that there's this radiolucency around that indicates a lower density or a complete loss of bone. And we can also see that in this x-ray over here, underneath this 3-unit bridge, where we have lots of alveolar bone loss. You can see that darkness underneath there. Next, we have the size. Radiolucent lesions viewed on a dental image can vary in size from several millimeters to several centimeters in diameter. And often the size of a lesion dictates the type of treatment necessary. Radiolucent lesions can be easily measured on a dental image with a millimeter ruler. And over here on this next image, we have kind of a comparison of what a millimeter it really is, or how big a millimeter is. So we can see the tip of a pencil is approximately 1 millimeter in diameter. The end of a pencil eraser is about 5 millimeters in diameter. So it just kind of gives you an idea of exactly how big a millimeter is. It's a very small size. So terms that we can use to describe radiopaque lesion. So a radiopaque lesion must be described in the patient record using appropriate terminology for appearance, location, and size. So appearance can be described as a focal opacity, a target lesion, a multifocal confluent, irregular, ground glass, or mixed lucent opaque. And radiopaque lesions occur not only in the bone, but the soft tissue as well. So the term focal opacity refers to a well-defined or localized radiopaque lesions on the dental image. Condensing osteitis, for example, or is an example of a radiopaque lesion that can be described as focal opacity. So they're talking about a pattern that would look like this on an x-ray. And here on the right, we can see what that looks like. It just looks like a blob of white. This is not a malignant process. Condensing osteitis is something that we'll see commonly, and some people have it. It's not really anything to be alarmed of, something that we'll just kind of watch on an ongoing basis to make sure it's not growing. A target lesion refers to a well-defined, localized radiopaque area surrounded by a uniform radiolucent halo. So a benign cementoblastoma is an example of a radiopacity described as a target lesion. So this would be a target lesion here on the left, and that's what the pattern would look like. And we'll see what that actually looks like on an x-ray to the right. So that would be a target lesion. And this just happens to be a benign cementoblastoma. So a multifocal confluent pattern can be described as multiple radiopacities that appear to overlap or flow together. So diseases such as osteitis deformans and florid osseous dysplasia exhibit a multifocal confluent radiopaque pattern. And multifocal confluent radiopacities that involve multiple quadrants of the jaws usually represent benign fibro-osseous disorders. So here's an example of the pattern of what that would look like to your left. And the x-ray to your right, it's not really easy to see there. There is actually that version on your book. It's a lot clearer on the book. But over here to the right, or your right of the x-ray, we'll see like little bubbles, radiopaque bubbles around there. And so that's what a multifocal confluent pattern would look like. An irregular or ill-defined opacity may exhibit an irregular or poorly defined pattern. So irregular radiopacities may represent a malignant condition. Examples of regular ill-defined radiopaque lesions include osteosarcoma and chondrosarcoma. And this is sort of what that pattern would look like that we're looking for in an X-ray. It's kind of an irregular growth, which is never a good thing. We can see what that looks like on this panoramic X-ray here. It looks like a growth pattern that shouldn't be there on that patient's lower jaw. A ground glass appearance of bone can be described as a granular or pebbled radiopacity that resembles pulverized glass. A ground glass radiopacity is often said to resemble the texture of an orange peel. Diseases such as fibrous dysplasia, osteitis deformans, and osteopetrosis may exhibit a ground glass or orange peel appearance. You can kind of see it sort of looks like, I don't know about ground glass, but it looks like an orange peel. And again, it's hard to see on this image of the X-ray. It's actually looks like, well, an orange peel, for lack of better words. If you look on your book, though, I believe it is on page 376. This is figure 31-17. And you can see a better representation of what that looks like there. A mixed, lucent, opaque lesion is a lesion that exhibits both radiopaque and radiolucent components. A mixed lucent radiopaque lesion often represents calcifying tumors. Many such tumors appear as a radiolucent area with central opaque flecks or calcifications. An example of a mixed lucent opaque lesion is a compound odontoma. And that's, it would sort of look like this here. We see this pattern of radiolucent areas, sort of speckled with radiopaque spots. And here's an occlusal image of, looks like a lower jaw. And we can see what that compound odontoma looks like there. Soft tissue opacity appears as a well-defined radiopaque area in the soft tissue. Some examples are scilith or a calcified lymph node. And we can sort of see what that pattern looks like here. Here's another occlusal image of a lower jaw. And we just kind of see this little radiopaque area or lesion here. And that's what that would look like in an X-ray. So as with radiolucent lesions, radiopaque lesions can also be described in terms of location. Radiopaque lesions may appear in the same location as radiolucent lesions, and that can be in the periapical, interradicular, edentulous, or pericoronal locations. The term periapical refers to the area around the apex of the tooth. An example of a periapical radiopacity would be a benign cementoblastoma. And that's what that would look like here. It sort of looks like condensing osteitis, but we can see the difference here. There's like a little halo, radiolucent halo that goes around that round radiopacity. And that's just, it's just an abnormal bone growth that is benign or non-cancerous. An interradicular location refers to the area, again, between the roots of the adjacent teeth. An example of a radiopaque lesion found in an interradicular location is a sclerotic bone. And then we can kind of see what that looks like. The pattern is here, and then a practical image here, what that would look like in an X-ray. The term edentulous zone refers to an area without teeth. And an example of a radiopaque lesion in an edentulous zone is a complex odontoma. A variety of radiopaque lesions may occur in an edentulous zone. And that's why we take, another reason why we take a panoramic X-ray. A lot of the times with intraoral images, we kind of miss all the surrounding structures of the jaw, especially if a patient comes in that's completely edentulous or has no teeth. It's very rare that anybody's going to be taking intraoral images on them just because there's nothing much to take. But a panoramic or another extraoral image shows a great deal about the patient's jaw and surrounding structures, as well as the pathology that we can sometimes find there. A pericoronal location refers to the area around the crown of an impacted tooth. An adenomatoid odontogenic tumor is an example of a mixed lucent opaque lesion seen in a pericoronal location. So here is that another mixed lucent opaque lesion. It's mostly radiolucent with speckles of radiopacities inside. Here we can sort of see what that looks like on this extraoral image here. And that's something really crazy. You probably won't see something like this every day. But that's what that would look like. So the radiopaque lesions can vary in size from several millimeters to several centimeters in diameter and can be easily measured on a dental image with a ruler. Documentation of the size of the lesion is important for treatment decisions as well as for comparative purposes. And that's all for this chapter. If you have any questions, feel free to email me or ask me in class. Thanks again for listening. We'll talk soon.